Thank you very much, Dr. Prasanna Kumar. It's really a pleasure to be with you today at this wonderful conference. So I was asked to provide a perspective on what we've learned from cardiovascular clinical trials in the area of type 2 diabetes, and I hope to do so during the course of the next 20 minutes. But before I start providing you some of the evidence, let me start off actually by asking you a question, and I think this is a little bit out of, I guess this isn't, okay. Let me start off by asking the audience a question, and you can just raise your hands. The question I have for you is, can reductions in glycemia control as measured by hemoglobin A1C translate into reductions in cardiovascular events? And when I say cardiovascular events, I'm talking about macrovascular events. And how many of you think we can actually accomplish this? How many for no? How many? No. So you think that you can't. How many for yes? Okay, many of you think that you can reduce cardiovascular events. And how many of you have a qualified yes? Namely, yes, only if you treat for long periods, greater than 10 years. A few of you in the audience think so. And how about D? Yes, but only if you do so by avoiding hypoglycemia. Any for that? Okay, so this is precisely my point. So depending upon who you are and what you've read, you might come up with any of these answers, and you can find a paper or two that supports one of these four choices. I think what we can summarize based on the large clinical trials that are focused on improving glycemia outcome, in particular ACCORD, ADVANCE, and VADT, is summarized in this slide in a cartoon manner. So on the y-axis is hemoglobin A1C. On the x-axis is time since the diagnosis of type 2 diabetes. And you'll notice that if you happen to be a patient that participated in UKPDS, which predominantly looked at newly diagnosed type 2 diabetes or patients recently diagnosed with type 2 diabetes, and you drove glucose down, then this translated quite rapidly into reductions in aggregate cardiovascular outcomes, mostly driven by reductions in microvascular outcomes, and you're very familiar with the data. On the other hand, if you're looking at a patient population that participated in ACCORD, ADVANCE, or VADT, and this was a much more sicker patient population with a long duration of disease, the mean duration of diabetes was anywhere from 10 to 12 years in these studies, and you try to lower glucose abruptly, and you do so in the context of a lot of atherosclerosis and atherosclerosis-related complications which have already manifested themselves in this patient population. You're not going to divine benefits of glycemia control, even if you accomplish glycemia control fairly aggressively, as was done in this clinical trial population. So we've learned that the duration of type 2 diabetes obviously has an important influence on whether or not you're going to divine benefits from a macrovascular perspective. We've also learned that some of the benefits of reducing glycemia or improving glycemia control often takes a fair amount of time to manifest, and this is referred to as a legacy effect. This is somewhat controversial because a most recent analysis from the ADVANCE trial, for instance, did not really reaffirm this faith in the legacy relationship. However, the UKPDS, as well as the long-term follow-up of the DCCT, clearly showed that once you participated in those two studies for a duration of time that may range anywhere from 4 to 5 years, and you came off treatment, you often derived benefit, even if you're off treatment and your hemoglobin A1C curves, if you participated in UKPDS or DCCT, converged, you went on to derive benefit from glycemia control during the duration of the study many years later, approximately 10 years later. Right? So most people, I think, based on this data, have come to the conclusion that perhaps reduction in macrovascular outcomes in type 2 diabetes takes a certain duration of time, and if it happens, it's much more likely to happen in patients who are recently diagnosed with diabetes who do not have a large burden of subclinical cardiovascular disease already existed. And this is also summarized in a different way in this meta-analysis of the 3 trials, ACCORD, ADVANCE, and VADT, in a meta-analysis published by Turnbull, that clearly shows you that the duration of diabetes, shown here as less than 5 years versus 5 to 10 years and greater than 10 years, is an important determinant of benefit from a reduction in major cardiovascular outcomes perspective. And again, the presence of macrovascular disease, which again is testament to the fact that you have overt disease, is often a clue whether or not you're going to derive benefit. So if you did not have macrovascular disease at the outset, then you're much more likely to derive benefits from aggressive glycemia control. And this could also be measured in the form of things like coronary artery calcium score. There was an interesting sub-analysis from the VADT study showing that patients who have low levels of coronary artery calcium scores, which is once again a surrogate for macrovascular disease, is often a good index of whether or not you would benefit. So lower the coronary calcium score, the more likely that you might derive benefit from aggressive glycemia control. Now, there's some recent analysis, and this is a post-hoc analysis of the ACCORD study published in The Lancet in late 2014. Most people believe, and most people missed the fact that even in ACCORD, there was a 10% reduction in the primary endpoint. Although ACCORD was terminated early, there was a 10% reduction in the primary endpoint, namely death, myocardial infarction, non-fatal MI, non-fatal stroke. And this was further elucidated upon in this post-hoc analysis published here. And it clearly shows a consistent benefit in a variety of different cardiovascular endpoints, including non-fatal MI, coronary revascularization, unstable angina, as well as new onset angina. And all of these, you can see the point estimates are well to the other side of unity, showing a benefit. And once you adjusted for hemoglobin A1C, you can actually completely turn all of these point estimates to unity right here. In other words, all of the benefits, at least in this post-hoc analysis from ACCORD, were based on the improvements of hemoglobin A1C. And this occurred within a span, as you know, of 3.6 years, which is when ACCORD was terminated. And there was a follow-up phase of approximately 1.7 years where patients were told to go back to the usual form of glycemia control. But this analysis again reaffirms the fact that you can actually derive benefits from a cardiovascular perspective, not coronary mortality, however, but a range of other macrovascular events pertinent to type 2 diabetes. And yes, indeed, you can turn the clock on macrovascular events in type 2 diabetes with aggressive glycemia control within 5 years. Okay, another important lesson that we have learned from clinical trials in type 2 diabetes is to avoid hypoglycemia. Hypoglycemia obviously has a very complex relationship with cardiovascular events, but it certainly turns out to be a very good surrogate for a patient population who's at risk for major adverse cardiovascular events. And this is an analysis taken from the ADVANCE trial, showing a very consistent association between the presence of hypoglycemia and susceptibility to macrovascular events. And you can note that the hazard ratio is 3.45. Again, all-cause mortality was also related to presence of hypoglycemia, and mortality from cardiovascular causes also was robustly associated with hypoglycemia. Now, whether or not hypoglycemia mediates these events is far more controversial, and certainly in ACCORD there was no evidence to suggest that hypoglycemia mediated excess mortality or cardiovascular mortality. There was absolutely no evidence to support that. But it certainly, I think, can be said that hypoglycemia represents a very good surrogate for a patient population who's at high risk. So it's best to avoid hypoglycemia, and if hypoglycemia occurs in a patient population, that's a poor surrogate. We've also learned that how you lower glucose seems to make a huge difference, right? We've learned from trials like PROACTIVE that pioglitazone, which happens to be a PPAR gamma activator, is a powerful strategy in patients with insulin resistance to lower cardiovascular events. This has also been affirmed with a number of different surrogate markers for major adverse cardiovascular events, including atheroma progression using intravascular coronary ultrasound, as was done in the Periscope trial, as well as CIMT, or carotid intermediate thickness, done in the Chicago study. So there's a body of data that consistently shows that treatment with pioglitazone, a PPAR gamma activator, could potentially beneficially alter major adverse cardiovascular events in type 2 diabetes. In contrast, the usage of a strategy that combines a PPAR alpha with the PPAR gamma, in this case this happens to be alaglitazar, and you might recall a previous adverse experience with another PPAR alpha gamma activator, moraglitazar, which was also terminated. The program was terminated early, and unfortunately alaglitazar, although will look very promising from a glycemia lowering perspective, as well as a raising HDL cholesterol perspective, was not so good in terms of adverse events, i.e. in the form of increased heart failure susceptibility for alaglitazar compared to placebo. There's roughly a 15 to 20% increase in heart failure risk. There's also an excess of GI hemorrhage and renal dysfunction with alaglitazar. So although conceptually the notion of PPAR alpha and gamma combined in a single molecule seemed very attractive, this is certainly not what the trial showed in actual life. Origin clearly taught us that even though you could execute an exceptionally well done study, and this was again done in a UK-PDS type patient population, patients who had new onset type 2 diabetes or insulin resistance or IGT or IFG, who were treated aggressively with insulin replacement therapy versus control. And again, there was another arm to it, which looked at omega-3 fatty acids. But what we learned from Origin was the fact that despite achieving normal glycemia in a good percentage of patients, there's absolutely no impact on the primary endpoint, which is a cardiovascular endpoint of cardiovascular death and non-fatal myocardial infarction. And on the contrary, insulin resulted in excess weight and hypoglycemia. So once again, the type of strategy used to accomplish your objective of glycemia lowering could be a powerful determinant of alleviation in major adverse cardiovascular events. Now, skip a few years later after Origin, and you're now in the era of DPP-4 inhibitors. DPP-4 inhibitors obviously modulate levels of the incretins GLP-1 and GIP, and by virtue of doing so, they do this by an approach that blocks the catalytic site of dipeptidyl peptidase 4, which happens to be a molecule very similar to angiotensin-converting enzyme, and you inhibit the cleavage of these incretin peptides, you elevate the levels, and you get a number of different effects. It should also be noted that DPP-4 has a number of other physiologic functions, including the catalytic cleavage of a number of other substrates that might potentially modulate their effects from a cardiovascular perspective. Now, we have also learned that incretins like GLP and GIP have complex effects on a number of different pathways. In particular, they have the ability to modulate lipoprotein metabolism in a favorable manner, in particular postprandial lipids. They exert obvious effects on the pancreas, both the alpha cells, where they exert an effect on glucagon secretion, and again, also exert powerful CNS effects by reducing appetite. And this whole totality of effects is probably responsible for why some of these drugs work the way they do. The big question for these drugs, obviously, were their cardiovascular efficacy. If you indeed hypothesize that they have a number of protective effects on the vasculature, they reduce lipoprotein metabolism, then one could intuit readily that they would probably have favorable effects from a cardiovascular perspective. And this was the anticipation, widespread anticipation for a number of these drugs. And this slide sort of goes through all the macrovascular outcome trials that are either already being performed or are being performed. TCOs will be presented at the American Diabetes Association meetings later this year, and there are at least 4 other trials looking at long-term cardiovascular events. There are at least 5 different trials looking at GLP-1 receptor outcomes, many of which are anticipated in the year 2016 and beyond. Now, 2 trials have already been presented. Many of you might be familiar with some of the data, and in the next few slides, we'll go through some of the results from both Examine as well as SAVOR-TIMI. Now, Examine was a trial specifically designed with the pre-specified hypothesis that allogliptin, a DPP-4 inhibitor, was non-inferior to placebo in a very high-risk patient population. And the trial was specifically designed to fulfill the FDA safety perspective, because the FDA at that time came back and said, well, you have to show us that your drug is reasonably safe within a margin of error. And once you do that, you can have regulatory approval. So this trial was designed in a very high-risk patient population with acute coronary syndrome. These were patients who just sustained an ACS. All of them are type 2 diabetics. And again, the primary objective is non-inferiority of allogliptin from a safety perspective. And the cardiovascular endpoint, the primary endpoint, was non-fatal MI, stroke, and cardiovascular death. There was also a secondary analysis, secondary endpoints, which is a composite endpoint of all-cause cardiovascular mortality, non-fatal MI, stroke, and urgent revascularization. And as we will discuss later, also a post-hoc analysis of heart failure hospitalization that was also captured as part of the study. So here's what the trial looked like. This was a fairly large study involving 5,400 patients randomized to receive either allogliptin or placebo recently after an acute coronary syndrome event. The preponderant majority were males, and there was a good representation from across the globe, 20% Asian. A mean duration of diabetes is 7 years, and the mean time from the index event was roughly 44 days. The vast majority of patients who participated in the study did so because they had sustained a recent non-ST segment elevation infarction. This is an exceptionally well-treated patient population. An important point to keep in mind, very much different from trials done in the early 2000s or the 1990s, where this wasn't the standard of care. As you'll note, more than 90% of patients were in statins, more than 80% received a RAS antagonist or a beta blocker, and 97% of patients were in antiplatelet agents. This was what their glycemia cocktail looked like. Most of the patients received metformin. There was roughly 30% of patients on insulin therapy, with a very small number of patients on thiazolidinediones. The vast majority of them are either in sulfonylureas or metformin. This was a change in baseline in glycated hemoglobin. You will note that the difference was a small minus 0.36%, probably because of the concomitant usage of glycemia-lowering therapy in the placebo arm that really resulted in attenuation of differences between the two groups. The primary endpoint was again superimposable between allogliptin versus placebo. The hazard ratio was 0.96. And again, this crossed, the confidence intervals crossed unity. This is what the events looked like. Again, the hazard ratio was 0.96. There was an interesting trend towards a reduction in cardiovascular mortality. There's roughly 89 cases of cardiovascular death in allogliptin versus 111 in placebo, with a similar number of non-fatal myocardial infarction and stroke. And you can look at the Kaplan-Meier curves for cardiovascular mortality, and you almost see a trend towards a reduction in allogliptin. And again, one should really take this with a grain of salt. There was a number of pre-specified secondary analyses done in the study, and one of the important analyses that was received a lot of attention, and this was published very recently in the journal Lancet, but Fayaz Anad, was the analysis, the post-hoc analysis of heart failure. The definition of heart failure was a stringent definition as used in most clinical trials of heart failure, which is this. You have to have both the clinical manifestations of heart failure as well as meet the criteria for needing inpatient treatment, either pharmacologic or dialysis-based approaches for heart failure treatment or mechanical or surgical intervention. So this is a post-hoc composite endpoint inclusive of cardiovascular mortality and hospitalized heart failure, and this is the same endpoint divided up into cardiovascular mortality versus heart failure. You will notice that there was a 19% excess risk for heart failure. Again, this was not significant, wide confidence intervals. and roughly 17 excess cases of heart failure in the allogliptin versus placebo that was not significant. Now, this was the first occurrence. First occurrence is an important analysis because many of these patients come back with recurrent episodes of heart failure. So looking at first onset of heart failure is a pretty important metric. And when you look at the number of cases who presented with first onset heart failure, this was virtually identical between the allogliptin and placebo arm with the hazard ratio of 1.07, again statistically non-significant. This is an interesting analysis looking at the influence of a diagnosis of heart failure on the cumulative incidence of events. And if you stratify patients according to whether or not they had no heart failure at the outset, clearly a much lower risk patient population, the Kaplan-Meier curves were virtually superimposable. On the other hand, when you take a patient population with a diagnosis of pre-existing heart failure, you will note that the curves almost seem to suggest that allogliptin perhaps might even be safer compared to placebo. But again, these are small numbers. Again, a post-hoc analysis must be taken with a grain of salt. A very interesting analysis performed as part of Examine was an analysis done by BNP levels. These are the ACCF-AHA guidelines on usage of BNP. Brain natriuretic peptide is a marker for diagnosis and prognosis, and you'll note that BNP is a very well acknowledged and widely validated strategy in both ambulatory patients with dyspnea as well as establishing prognosis of disease severity, and also has a class 2B indication for serial measurements. So you can derive a lot of different aspects on prognosis as well as pharmacologic management of patients by measuring BNP levels. So a very interesting analysis was done using BNP levels, and you'll notice that when you stratify patients according to treatment and by level or quartile of NT-proBNP, patients who are the highest quartile of NT-proBNP, while clearly at higher risk for heart failure, demonstrated no stratification or no difference according to whether or not they were treated with allogliptin or placebo. In other words, there was not an excess risk in the highest quartile of BNP if you were treated with allogliptin. So there's virtually no difference. So this was actually a very reassuring signal that seemed to suggest that allogliptin is safe regardless of whether or not you have pre-existing heart failure or high levels of NT-proBNP. Now, in the last few minutes to provide the contrast, I'll also share with you data from SAVOR-TIMI, which is also published at around the same time as Examine. This is a much larger study and involved the usage of the drug Saxagliptin in established in patients with type 2 diabetes at high risk for future cardiovascular events. This was an event-driven analysis and again looked at the major endpoint of cardiovascular death and myocardial infarction. The trial included not only patients with established macrovascular disease, but also patients with multiple cardiac risk factors. So the primary endpoint, which also included stroke, was virtually superimposable. And the analysis, as you know, was conducted after a duration of 24 months. And we've also learned, as I mentioned very early on, that the duration of follow-up is very important. It's seldom that you find benefit, even if you had a spectacularly useful drug in type 2 diabetes, you're likely to see a benefit within 2 years. And not surprisingly, the Kaplan-Meier curves for both placebo and Saxagliptin were superimposable. What was very interesting was a signal for heart failure in Saxagliptin, which was pre-specified as part of the analysis, as part of the primary analysis, and there was a 27% excess risk for heart failure in Saxagliptin compared to placebo with a highly significant p-value. Now, this analysis was initially done as part of SAVOR, where patients were stratified based on BNP. And one of the reasons this was done was because BNP happens to be a target, happens to be a pharmacologic substrate for DPP-4. So the thought at that time, when this was put together, was that perhaps high levels of BNP might be a patient population that might have unique benefit, not harm, with Saxagliptin. But it turns out that BNP is a target for DPP-4, not NT-proBNP. But nevertheless, when they examined the patient population and stratified them based on quartiles of BNP, you'll notice that there was a higher risk in patients overall But not only that, there was a preferential risk in those assigned to treatment with Saxagliptin compared to placebo. And you'll notice that the hazard ratio here was 1.31 in the highest quartile of BNP. When they performed a multivariate analysis looking at the variables associated with susceptibility for heart failure, hospitalization, and SAVOR, these are the things that propped up. Prior heart failure, presence of CKD, urinary albuminuria, clearly, advanced age, established coronary artery disease, as well as female sex. And this is, again, sort of the Kaplan-Meier analysis of how heart failure develops in SAVOR-TIMI. Most of the heart failure occurred within the first 12 months of treatment. And after that, the Kaplan-Meier curves are virtually parallel. The risk remained consistent after that. And this does not seem to be related to a weight gain phenomena, which is often the case with thiazolidinediones. Neither did it relate to indices of injury, for instance, elevations of troponin in patients treated with Saxagliptin. There's no indication that there's an elevation of troponin in response to Saxagliptin. And this is what the absolute risk really translates into. The number of excess heart failure events per year ranged from 0 if you had no risk factors. In other words, if you're not elderly, if you do not have evidence of CKD, and if you had no heart failure previously, your risk is virtually 0. On the other hand, if you had all 3 risk factors, your risk was roughly 9 patients in every 1,000 patients treated would have an episode of heart failure, which is relatively small to speak of. So in my last 2 slides, I'll just summarize to you what we have learned and gained from cardiovascular clinical trials in type 2 diabetes. And I think we have a body of evidence that supports the concept that the duration of diabetes or vintage in type 2 diabetes is an important consideration. The longer the duration of type 2 diabetes, the less likely you are to derive benefit from aggressive glycemia control. Again, the legacy phenomenon is sort of controversial now, but at least there is data from DCCT as well as UKPDS, not so much from ADVANCE to support the concept. We have learned from EXAMINE that strategies, and SAVOR, the strategies like alogliptin or saxagliptin, and hopefully other DPP-4 inhibitors are safe from a major adverse cardiovascular event perspective. In EXAMINE, clearly the pre-specified non-inferiority margin was met, and at least in ACS, in a very high-risk patient population in EXAMINE, there did not seem to be any evidence of excess heart failure. Now, saxagliptin, again, was safe and was comparable to placebo from a cardiovascular event perspective. There did seem to be a small increase in risk, again, very small, for heart failure hospitalization. And from a clinical perspective, if you were to avoid advanced age, presence of CKD, or presence of pre-existing heart failure, you can absolutely eliminate the risk associated with this drug for heart failure. Whether or not this is a class phenomenon needs to be further delineated, and we look forward to trials like TCOS as well as future trials like Carmelina to really inform us and provide better perspective on this association. At the present time, I think the presence of an elevated BNP appears to be a relatively good way to, again, stratify risk, especially on those in whom you're contemplating therapy with Saxagliptin. So I'll stop there and thank you for your attention.